our objectives for today are to talk about medication safety, and a lot of what I'll discuss will be specific to the hospital environment, but you will very much be able to see why these will be applicable to all settings, no matter where you're practicing. So we'll talk about meaning of the medication error. We'll look at implications for individual versus system and how we work through that, or how we should work through those errors when they occur. We'll talk about the pharmacist's role in medication error prevention, and then I'll also point you all to some resources that you'll be able to use as you move forward in practice that will be helpful to you as well. Does anybody know where this is? Does anyone know? Anybody know what hospital this is? That is Vanderbilt. Vanderbilt Medical Center. Have you all heard anything recently about them in the news and the medication error that they had there? Very unfortunate event. So this has occurred in the past year. I have had the good fortune of actually visiting Vanderbilt Medical Center, and I can say that they are very, very much in the forefront of the things that they've been able to do in regards to technology and innovation, and really, really doing some cool things in pharmacy. I say all that to say that the error that occurred there could happen anywhere, any hospital, USA. They had a patient who came in and was scheduled to have an MRI. She had a nurse who was providing care for her and required some degree of sedation. She was nervous before she got ready to go in and have her scan done. The nurse on the floor was responsible for getting the patient to the scan of the radiology and had to run back down really quickly to get the medication that she needed for the patient. She goes to the Omnicell or the automated dispensing cabinet and types in VE. So VE could either be Versed or VE could be vecuronium. She pulled that drug, went back to MRI, gave the patient the injection, went back downstairs to take care of her patient. Her other patient. Unfortunately, that patient died awake. It was not Versed, it was vecuronium. And so the patient achieved paralysis to the point, she's awake, keep in mind. She can't breathe, she can't move, she can't yell, she can't do anything. And so when the nurse came back upstairs to check on the patient, she discovered that she was unresponsive. And they attempted to resuscitate the patient at that point. It was at that point in time that she went to pull what they were looking at documentation, trying to figure out what was going on, that they realized that she'd actually given the patient vecuronium. Unfortunately, that patient passed away. There's so much that goes into this story, and Vanderbilt has actually been gracious enough to the rest of us to share exactly the circumstances around the error, the fact that you could type in VE and access vecuronium so easily that it wasn't in a locked container. Now, keep in mind, vecuronium does have all over it that it's a paralyzing agent. Versed, which is midazolam, typically comes as a liquid. Vecuronium comes as a powder that you have to reconstitute. So there are a lot of triggers that should have been there to warn the nurse that she was not getting the right thing for her patient. But sometimes when we're in environments where we're distracted and we're moving very quickly, we fail to look at all the warning signs that may come to us. You know, of course, because this is typically an emergency medication, it's not something that the pharmacist is going to review. It's typically on override, which is a mechanism where nurses can get the medications they need if they need them in a hurry. And so there was no opportunity for pharmacist intervention at that point. This is unfortunate also because the system failed this nurse. It was determined that if someone else were potentially placed in this nurse's shoes, they could have made the same area. Think about a new grad nurse who's not necessarily 100% familiar with all the medication. This nurse was arrested. This nurse went to jail. This nurse was charged with murder. in this patient case. The other thing that happened along the lines of this is that Vanderbilt and many hospitals actually are moving towards a space of just culture. And what just culture means is that it's not about finding fault. It's about getting to the ultimate root of why an error occurred. And the purpose for that is so that everyone can feel safe in the environment that they work in. If people fear retaliation or they fear punishment, then they're less likely to bring up issues when they occur. They're more likely to cover them up and hide them. And so we talk a lot about just culture. So Vanderbilt approached this from a just culture perspective and walked through the algorithm, which we'll look at a little bit later today, to figure out exactly why the errors occurred, what things they could do to mitigate the errors, and they unfortunately did not report it to the state in such a way that they felt comfortable that the investigation was thorough and they had learned from what had occurred. And so that meant some things with them, for them with the state hospital board. It meant some things to them from a Centers for Medicare and Medicaid perspective, and whether or not they were going to put them in what they call immediate jeopardy, which means that they will no longer pay you for taking care of their patients. And so there were a lot of implications for the hospital, which they've resolved and been able to move past. The nurse is still, her trial is still pending as to what her ultimate outcome will be. We won't know. But I like to start with examples like that, because as we go through the day and talk about all the different places where errors could occur, the pharmacist's role is not just a finite space of making sure that the physician got the drug right. There are a lot of other places where medication errors can occur, and we'll walk through some of that today. So, medication safety. The goal of drug therapy is achieving defined therapeutic outcomes that improve a patient's quality of life while minimizing risk. More than 10,000 prescription medications are available to prescribers. God, I've been out of school for too long now, but there has been so much that's come to the market and is available that I've got my board certification, so I forced myself to keep up with it all. But imagine being a prescriber and for all the different options that are available to you, knowing every detail about each one of those. Well, as a pharmacist, they expect us to do it. I say that there's no way to keep up with all of them, but you better know what you know and know what you don't know. And so there is a potential for as all of these new things are coming to the market, to have room for error. Nearly 1/3 of adults take 5 medications or more. So it's a lot for our patients to keep up with as well. Adverse drug events account for nearly 700,000 emergency department visits and 100,000 hospitalizations each year. We see them all the time, and so this is one of those things where we think about it from a population health perspective. And I've talked in the past about the importance of the connectivity between the retail environment, ambulatory environment, hospital environment, and how as a profession we kind of put ourselves into corners. But I firmly believe that as we work for the best interest of the patient, that it's important to maintain those open channels across the spectrum so that we can keep our patients safe. The reason why I say that is because when we have patients who come in for hospitalizations related to medication errors that may occur in the community setting, my question is always, did we reach back out to that pharmacy where it was filled so that they're aware that the error occurred and that not just seeing it in isolation, because we see that occasionally. So what is a medication error? It's any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or the consumer. Such events may be related to professional practice, different healthcare products, procedures, systems including prescribing, order communication, the way that we label products, packaging, nomenclature and compounding, dispensing, distribution, administration. Sometimes we have errors in education, monitoring and use. So this is just to show that it can occur across any spectrum of the medication use process. So one of the things that's important to do is to back up a little bit and talk about the differences between the way that medication errors may be classified. So there's this thing that we call preventable adverse drug events. Result from a medication error that reaches the patient and causes any degree of harm. Roughly all errors are preventable. So the example that I gave at Vanderbilt, that was preventable. Potential adverse drug events are not the same as preventable adverse drug events. Some things that could happen is that you would have patients, they don't necessarily cause harm because they're, oh, I'm sorry, I've got things backed up. Hold on. Potential adverse drug events are those things that do not reach the patient. Those are a lot of the places where we're making interventions. So we see the error, we catch it, we make sure that it doesn't reach the patient. For ameliorable adverse drug events, the patient experiences harm from the medication, while not completely preventable, could have been mitigated. An example here, vancomycin. If you infuse too quickly, and rates can be dependent on what the patient can tolerate, they may develop red man syndrome. So it's not completely preventable, but there are things that you could do to keep that from happening to the patient. And then here's the one that I was getting confused earlier, but adverse drug reactions or non-preventable ADEs are when harm occurs even when medications are prescribed and administered appropriately. And so we think about these as being things such as a rash after getting an antibiotic that no one knew that you were allergic to. You didn't know you were allergic to it. It could be very often the things that we identify as side effects. And even if we use them as we're supposed to, you may have a patient who has a reaction to it. And so we try to create the distinction between a medication error and an adverse drug event. A lot of times when they're reported to us, they're all lumped into one bucket. It really comes down to what's preventable and what's non-preventable. So what are the types of medication errors? I've talked about this earlier. We could have a prescribing error. It could be an error of omission. We recently had a case where we're trying to make sure that our patients who need DVT prophylaxis have DVT prophylaxis. But if for some reason we decided there was a contraindication and we don't give it, and there's an adverse outcome, it could be an error of omission. Wrong time, an unauthorized drug, improper dose, wrong dosage form, the wrong drug preparation, the wrong administration technique, and there's been a lot of work in this space over time, deteriorated drug monitoring as well as compliance. So, where can medication errors occur? I showed this to you all in the past. It can occur at any one of these steps of the medication use process. So, one of the things that we talk about, and what we're getting ready to move in now, are the different factors that lead to medication errors. And so I'm going to start from the very first part of the medication use process, which is the prescribing space. One of the things that we are doing at Emory right now is we are moving towards what we call a lean environment, or the Toyota method of delivering care to our patients. And one of the things that's emphasized there is keeping an orderly environment in which you work in, reducing waste, reducing mess, reducing noise and nuisances. And so very often when we have errors occur in our space, we find that there are environmental factors that go along with that, whether it's because they're cluttered, because there's noise and distraction, whether there are poorly lit workspaces, lack of planning. Everybody likes to be off at the same time, and so there are staffing shortages, and we have surges. Flu season is a good example of that, when we may not be able to keep up with demand. And so I say all of that to say, to point out that the first step in reducing errors is creating an environment that's conducive to work. And I tell pharmacists this all the time, new grads this, don't take jobs in places that you don't feel comfortable in for the sake of taking the job. If you walk into the environment and it looks like things are falling apart, they probably are. So don't put your license in that predicament. The environment means everything. because very often the environment will also determine just the culture that is involved in that environment as well. So now we're going to move on to our drugs themselves. Look-alike labels, packages, look-alike, sound-alike drugs are something that come up very often. The FDA and how they decided how medications get named, and when you start talking about biosimilars, it becomes even more complex, are one of the contributors to medication errors. You can name a drug pretty much whatever you want to name it. It doesn't matter if it's similar to something else or not. So this is one of the things that we look at as we're bringing new medications into our environment, whether or not there's any room for it to be confused with something else. Ambiguous labels on medication. Unlabeled medications comes up often. Mislabeled medications, or doses dispensed in bulk without patient-specific labels. So when you think about all the things that could go wrong from the drug product itself, this highlights those for you. With the drug names, labels, and packages, there are some things that we can do to mitigate the potential for errors. Tall man lettering, making sure that if we have things that aren't labeled or they're ambiguous, we may apply additional labeling to them. Unlabeled medications or syringes is a big one. I think I spoke previously about the difference between propofol and Exparel, which is liposomal bupivacaine. Both of those are used in the OR setting. They're both a white milky substance. Propofol is for sedation. Liposomal bupivacaine, not so much. You inject it on the, you insert it at the surgical site. If the two get mixed up, that is bad. And so one of the least favorite things for our anesthesiologists to do is label. And so that is something that the Joint Commission has made as a standard. That is something that we look at and make sure people have good habits and practices with to avoid errors. Mislabeled medications, one of the other things that we make sure that we're mindful of is that if you don't like to label, one of the workarounds that you may put in place is actually labeling all your syringes ahead of time so that you can just batch them all together. But if you have a bunch of syringes that are sitting out that are pre-labeled, what that prevents you from doing is looking at the drug that you're making and making sure that the label is appropriate, and that's very often where mislabeling occurs. And then, again, dosing dispensed in bulk without patient-specific labels. So here's some examples of look-alike labeling. You all have likely seen this. Our friends at Falcon, who do all of the eye drops, they look absolutely identical. If you look at the heparin, this is a heparin 10,001 versus a Hep-Block Flush, which is typically 1,000 per one. This is where Dennis Quaid, are you on Dennis Quaid? You on Dennis Quaid? Okay. So Dennis Quaid, his twins, the heparin error, that occurred because of the mislabeling. There was a big case several years ago up in Indianapolis where there were infants in the NICU. You see both of these are blue. They very often use heparin in our NICU patients to keep their lines patent because the rates are so low in them that they'll very often close off. There's a big difference in a neonate with 10,000 units versus 1,000 units or lower of heparin. The technician refilled automated dispensing cabinet, put heparin in there. It was the wrong heparin. Nurses are pulling out heparin, not necessarily looking at them to make sure the concentration is correct. Unfortunately, that case in Indianapolis resulted in patient deaths, NICU patient deaths. So that was a really big case a couple of years ago. You'll also see that for look-alike labeling, that the bulk bottles that are sometimes prepared by the manufacturers look very, very similar, so that makes an opportunity for error as well. The other thing too is there was, when my first kid was born, he's a junior in high school now, I could go to the drugstore or I could go to the grocery store, and if he had an issue with congestion or just allergies or whatever it was, there were all these options on the shelf. And I, because I was in pharmacy school at the time and kind of had some wherewithal about me, knew to look at the labeling and the specific ingredients to make sure that cough and cold was different and had some overlap with cough and allergy as far as the ingredients went. They've taken a lot of those products off the market because of the number of pediatric deaths they had with people not just confusing the labeling between them, but not realizing that there was overlapping in the ingredients that were in those products. And so, pain reliever is likely the same thing as Pediarelief. And so there's opportunity to get those mixed up as well. So one of the things, and if we won't go through it today, but that you can go back to, is that ISMP, which is the Institute for Safe Medication Practices, it has a plethora of resources that are available to you, not only as a pharmacist, but also to use with your patients. They have a place where patients can go on themselves and report medication errors if they see them. If you have near misses that occur in your pharmacy and you're out in the retail environment where something just doesn't seem right, you can go to ISMP and report it as well. They take all of those cases as they're reported across the country, and they will trend and work with the FDA if they're seeing trends in particular places, or they will actually include them in their newsletter and make awareness and education around those products. So I've provided that link so that you all can get to that. And then this is the most common reason for medication errors worldwide. You want to make sure that you remember that because things look alike and sound alike. Okay, so the other opportunity for error in this space is with confusing packaging. This one was actually published in an ISMP newsletter. Our good friends at Exactidose were preparing phenytoin 100 milligrams in 4 mL. And they had been doing that for years and years and years, and people were accustomed to it coming this way. This is something that you'll typically use in the hospital. It was 4 mL delivered, exactly 4 mL. And someone there, I don't know who it was, came up with the bright idea of repackaging their product and preparing it in a 125 milligram per 5 ml. Well, do you see the note down there? This cup delivers 4 ml. So it was intended to provide the same dose. What they assumed is that when people open this packaging, you were going to take it and drink from it or squeeze it out, and the patient was going to give it that way. That's not really what happens. When the nurses are administering medication, their goal is to make sure the patient gets it all. And so not only were they withdrawing the entire content and giving it to the patient, sometimes they were also rinsing the cup to make sure they got it all out, which meant that the patient was getting more than what their intended dose was. And if you imagine being a pediatric patient and that additional 25 milligrams of phenytoin, that's significant for them. And so they had to revert back to their original packaging. I don't know why they did that, but this resulted in many errors in dosing that had to be rectified. So moving along, drug names, labels, and packaging. When we have medications that look similar or can be confused very easily, there are some strategies that we can take on. We can physically separate those items that are packaged similarly. Good example here, vaccines. And we make an effort to make sure that if there are vaccines that look very similar, that we keep those separated in our shelves. In our refrigerators, the use of tall man lettering, the ISMP list will show you what that looks like. Warning labels for unusual strengths or special precautions. Indication for PRN or as-needed medication. So this is another example, hydralazine versus hydroxyzine, which are very often used on an as-needed, well, no, one of them is. Hydralazine is for blood pressure. That's typically scheduled. Hydroxyzine we very often use for itch or for sedation, relaxation, or sleep, or whatever it may be. But that's as needed. Physician, working very quickly, HYDR. They're likely to get hydralazine first because of the alphabetical nature. what we do is that we add an indication. So if those are available in our computer system, we will specifically say hydralazine for blood pressure, hydroxyzine for itch, to give another indicator for that potentially being the wrong medication. The other things around drug standardization, storage, and distribution, availability of multiple concentrations of drugs. We try to limit the different concentrations that we carry. Strategies around making sure that the nurses don't prepare their own IVs, that we're making as much in the pharmacy as possible so that there's not confusion there. Concentrated electrolytes, and I'll talk a little bit about that. Non-standard administration times. So for the thing about non-standard administration times when it comes to medication error prevention is that in the hospital setting, we typically have standard times that the nurses are pulling particular medications. So let's say warfarin. It seems to be universal that no matter where you go, warfarin is going to be given at 6 p.m. That's because you can check the INR in the morning. Very often, what we'll see with this is that if someone orders warfarin at an odd time, there's a bias that can't be right. And so there's opportunity for error around that. So we try to really push all our medications to standard administration times in the hospital setting. And it also helps the patients as well. So certain things are given at 10 a.m. if they're just once a day. Certain things may be given at 6 p.m. If we have drugs that are twice a day, they may be given at 10 and 6. But if they're every 6 hours, they may be on a different schedule. But all of that is to say that the nurses get very used to when medications are supposed to be given, and all of that has a science behind it to prevent errors. And then missing medications due to problems with pharmacy distribution. So again, with drug standardization, storage, and distribution, one of the things that we want to do is make sure that medications are where they need to be when the nurses need them. An opportunity for error here exists when nurses start shopping other patients' bins for drugs because they don't have the one that they need for the patient and they think they'll repay it later. We've seen less of this with barcode scanning because it links directly back to the patient, but there's opportunity for error there as well. So we look at the way that we store meds also. Here's another one that I wanted to point out. We talked about the heparin error before. This is again just to show you all how, what the opportunity is here when those can get confused. I talked about concentrated electrolytes earlier. The reason why this is important when it comes to medication safety and storage is that concentrated electrolytes typically have no reason to be in our nursing units. Those are intended to be diluted. They're within the pharmacy environment to be used to make drips. Those are within the pharmacy environment to make TPNs. But we really try to make sure that we do not have any instances of concentrated electrolytes on our floors when we're storing medication. So here's a quick question for you. Which of these is not a concentrated electrolyte? Any guys come in the room with me? Extra? That's really concentrated. Think about, so you start thinking about, okay, if I'm in the hospital and they're going to give me dextrose, it's usually 5%, right? D5W. So that was not considered concentrated. Not considered to be concentrated. And hence it's the one that's diluted. Yes. And so when we're sending out dextrose, sodium, calcium, potassium, these electrolytes out to the floor, this just goes to show there should be diluted in something else. And if they're not, they're probably a concentrated electrolyte. One of the recent ones that gives us a little bit of heartache is the sodium chloride 3%. So sodium chloride is typically, in its most concentrated form, is typically provided as 23% Normal saline is what? 0.9. So 3% is a concentrated electrolyte. What is that typically used for? Intracranial pressure in the neurology unit, in the emergency department. And when patients need that, it's typically an emergency. So we have to be very careful when we put it there, because there are parameters around how we store it, so that people don't potentially get that confused and think that it's okay to give to everyone. But when patients run sodium chloride 3%, they're usually having their intracranial pressure monitored continuously. So that is an instance where we might use it. Again, too, around the drug standardization, storage, and distribution space, we talked about the concentrated electrolytes. The other thing that we try to move towards is also standardizing concentrations. The reason why the standardizing of concentration matters is because when nurses go to program their infusions into a pump, or if we're preparing things in the pharmacy, we want the calculations to already be there and available for them to use so they know exactly how to give it. For the space of standardizing concentrations, we've had a very recent example of this. I'm super excited because we're in the process right now of getting to one infusion pump. Everybody uses the same infusion pump across the system. Right now we have 4. And if you go to each hospital, they have different concentrations. The issue with that is that our nurses go between the hospitals. So they're using different technology, but the drugs may be prepared differently. So there's no getting used to things being prepared a certain way. One example that we have that we're working on right now is that we have 7 different concentrations of Pitocin in our system that we're trying to get down to like 2, high and low. The reason why that matters is because it makes a difference whether you are inducing a mom for labor, or whether you've had a mom who's lost a baby in the concentration used, versus a mom that you're using Pitocin in post-delivery to reduce the risk for hemorrhage, and what happens in those different environments physiologically. And so with the standardizing of concentrations to high and low, we know that for induction, we will always be using low. For the other circumstances, we will always be using our high concentration. But when you have different concentrations, it's very difficult to understand which one should be used when. So standardization of concentrations is important. ASHP, ISMP, and there was another organization came up with an initiative 2 or 3 years ago called Standardized for Safety. What that work is around is getting a standard so that not only are we standardizing concentrations within our hospitals, but we're also standardizing concentrations across the country, so that people get used to this is the way that this should always be prepared. I did some work here several years ago when I was at the Children's Hospital, where the pediatric hospitals across the state were moving to standard concentrations, not only within the hospital, but also with EMS, so that no matter what environment our pediatric patients were in, and if they were going to use the Broslow tape to determine what dose they should get, it would be the same no matter where you were practicing in the state. So standardizing concentrations is a really good method for reducing error. Using commercially available premixes when possible. So this becomes a bit of an issue when you have drug shortages. So it is very nice when you can order the things that you need that are already prepared and ready to use. But when they're not, that means that the pharmacy is manually making all of those doses. And so we also have the room for error when we're put into that environment. If it's ready to use, our risk for error is less. Dispense medications from pharmacy within a reasonable time frame so we don't have the theft occurring. Removing concentrated electrolytes from patient units, and then not borrowing medications from patient supplies is also important. So I talked a little bit about the pumps earlier, and this is specific to medication delivery devices. But with the invention of smart pumps, we have the opportunity to reduce pump programming errors. When you have a smart pump, it includes a library. So the example I'll use here is insulin. With insulin, we typically make that as 100 units and 100 mLs. The pump is expecting 100 units and 100 mLs. So the nice thing about that is that I can tell it that if the nurse goes below this rate or above this rate, I want you to give her an alert letting her know that she's outside of our limits. But if she goes way outside, like 1,000 units per ml, to run over an hour, it won't let her do it. So that's how smart device technology works. We want to make sure that we take an opportunity to implement those in our settings wherever we can. And so that's important. Wrong route comes up occasionally, line mix-ups happen frequently, and then failure to utilize smart technology. So once you have it, if you have people overriding what's available. Medication delivery devices. The World Health Organization has done a good bit of work around this. So this is still related to administration. We've talked about limiting the number of devices you have to avoid confusion. Training and education is just a small step of what you can do. Independent double checks can come into play as well. Specially designed oral syringes, and then the smart technology could also come into play here. When it comes to the devices, you'll see here that I've given you all an image of a syringe. So this one is for injections. It's typically clear, although it can come in other colors, but it also has this male Lorlox tip, which means that it twists into the IV line when you're administering it to the patient. For oral medication, we would never want to prepare those in an IV syringe because the risk of giving an IV exists. And so we put these into an adapter that will only connect to feeding tubes, essentially. Because we still have so many errors with this, one of the things that the World Health Organization has done is to come up with different standards for delivery devices and how depending on the site of administration. So there will be a different standard for IV, which already exists. They've actually come up with a new locking mechanism, not only for the syringe, but also the point of entry for the patient. So now the feeding tubes will only connect to an oral tube. You can't make it connect any other way. This has been slow for adoption across the world, to be honest with you, but it's something that we're now looking at, particularly in our higher risk patient population, think about your pediatric patients. One of the other things that you all will find on the ISMP list is the high alert medications. All of these are considered high alert, high risk medications. These are the medications that are associated most commonly with medication errors. We talked about vecuronium in the beginning. It's also on that list. All neuromuscular blockers are. If you're in the hospital environment and you're looking at, and you're in a setting that hasn't done a lot of work in this space specifically, ISMP has really good resources that give you some suggestions about how to mitigate risk around those medications. So moving along, we've talked about all the different, and I've given several examples of where medication errors can occur, what we most commonly see. Which we're going to talk a little bit about the roles of the different individuals. One, and first and foremost, the prescriber. Knowledge is power. We are their friends, and if you're in the hospital environment, they typically get that. I was in a meeting the other day, and one of the physicians was saying, we're talking about interdisciplinary education, and one of the physicians says, I love it when my pharmacists are on rounds, even the pharmacy students, because they'll call and say that there's an issue with something, and then I'm like, just fix it. I'm like, no, we don't want to just fix it. We want you to know what's wrong and to get it for next time. But knowledge is power, and working with the pharmacist and having direct information is key. Medication reconciliation. This became a buzzword 10 plus years ago, knowing what the medication is on between the different settings of care so that we have an accurate list and we don't forget anything and we have the right doses. This role belongs to the physician in most settings. Pharmacists can also play a huge role in this, and even pharmacy technicians with getting accurate medication lists and making sure that we have everything accounted for. Training, familiarity with prescribing systems, making sure that they write complete medication orders, that things are not clear and unambiguous, and that they write legible prescriptions as well. Additionally, what we would like to make sure that prescribers do is that they read out instructions rather than use non-standard or ambiguous abbreviations. You may see that in the retail environment. We don't have it as much in our hospitals anymore because everything is electronic. Take as directed is unfortunate as well because patients don't always remember what the directions were when given to them verbally. Specify the exact dosage strengths, milligrams versus tablets, or vials versus amps. This very often comes up with sodium bicarb. So there, you can order that as 150 milliequivalents, which is very specific for 3 amps. We encourage the physicians, and will not fail that until we verify that that's exactly what they want. So we encourage them to use the actual dose. The other thing that we've seen recently is that many of our, for whatever reason, some of our systems were set up where for PCAs, which is patient-controlled analgesia for pain, were being prescribed in mLs. The issue with that is that you can have different concentrations and you have to backtrack to see exactly how much the patient got because mLs doesn't tell you anything. And so we're converting our systems over now where everything is in milligrams or micrograms. Prescribing by standard nomenclature. One of the things that's been good about technology is the ability to short text, right? So LOL, what are some other ones? The ones I'm thinking of, I can't stand here. Some other things that we may use in text, but that's not good with medication. You can't come up with your own abbreviations because everyone may not understand the shorthand that you're using. And so we will only fill things when it's the full name for the drug, not when it's some abbreviation or shorthand language that physicians kind of come up with on their own. Always use a leading zero before decimal and never a terminal zero, spelling out the units rather than writing U, and then also use of the metric system. So the other role of the prescriber is for verbal drug prescription orders, be reserved for situations in which it's possible or impractical for the prescriber to write the order. Not just going and telling a nurse to give something, but actually writing it down and confirming. Making sure that medications that can be given by the oral route are used when possible. There is risk every time a patient needs IV medication. There's less risk by nature with oral medications. Medication education for patients and caregivers is the role of the prescriber, but all caregivers, I say we have a role with that. Following up and evaluating the patient to determine whether they need therapy. So one of the things I pointed out earlier is that most of our patients are on 5 medications or more. And that contributes to the potential for medication errors. One of the ways to reduce risk is to not be on things you don't need. And so we encourage physicians to do that as well. And then also instructions with respect to hold orders should be clear. This very often comes up with antibiotics. If we're waiting on levels to come back, with anticoagulants, if patients are having procedures, and making sure that we don't just say for things to be held without any additional instructions around what else needs to happen. I'm going to skip back past these examples of ambiguous abbreviations, but they're available to you in the PowerPoint. Role of the nurse. So we talked about the physician and their prescribing. When it comes to the nurse, making sure that they're familiar with the systems that they're using, looking at the medications, therapies with respect to the outcomes. Drug information is huge. I mentioned all the different medications that are out there, making sure that they have access to references and use them if they encounter something that they don't know or understand. Making sure that orders are verified prior to administration. Patient identification is huge, making sure you give the right drug to the right patient. And then we talked about the standard administration times, giving the medications when they're due and not holding them for various reasons. Also with the nurse, we want to make sure that they're doing their calculations, their flow rates, using the technology that's available to them. We talked about borrowing medications earlier and not doing that. Questioning large volumes or number of dosage units. This is a true story and it's happened. So if you have to give more than 2 or 3 of a specific tablets of a specific medication, something is probably wrong. Anytime you get to double digits, something is definitely wrong. But it's happened. I know that we had levothyroxine at one point, tablets, and I saw a case where a nurse gave 18 tablets because it was micrograms, milligram error in the computer system. And that didn't alarm her, that she was having to pop out that many to administer. She did it, because that's what the computer told her to do. So we always talk about using, when we do our nursing orientation, using our noodle and having good common sense and clinical judgment, not just doing what it tells us to do for administration. Familiarity with infusion devices, patient education, and then of course listening to patient concerns. One of the things that our nurses have on their units are these medication safety zones. Back in the day, they would put down red tape, and it meant that if the nurse went into that space, she was getting prepared to administer medications, and it was a do not disturb sign. Now hospitals are very savvy where they will actually put red towels in, so that it's a permanent indication of once the nurse is in the space, that's medication safety. We do not disturb them when they're looking to do that. So that's another strategy for preventing medication errors and how we can help set people up for success. 5 rights of medication administration for all of our nurses every single time, making sure you have the right patient, medication, time, route, and dose. And you'll also hear some refer to the 8 rights of medication administration, and that you don't just give the medication and walk away and that's the end of where errors could occur. You want to make sure that they have the response that we intend for them to have, that it makes sense that you're giving the patient the medication. Yeah, they told you to give it, but is this even appropriate for this patient? And that the patient understands what they're getting and why. Because all of those coming together help prevent medication errors. The role of the pharmacist. So drug therapy monitoring, medication ordering system. We have a big role that we play in developing the policies, procedures, how things are built into the system, where they can be used, how they can be used, stopping and clarifying every single time that we think that there may be an error, keeping our environments in a good place where we can work with them, in reviewing orders in non-emergency situations. So there shouldn't be any pockets where we have a tolerance for people just going ahead and getting medications. We always want to make sure that they're being used appropriately. High-risk medication double checks and putting those in place very often comes up with chemotherapy. We talked about ready to use, making sure things are labeled well, getting them up there on time. We have a huge role in patient education, counseling, using order form sets, sheets, pre-printed, wherever we can, as well to prevent medication errors. So for the role of the patient knowing what they're on is critical. Keeping a list is something we should be educating all of our patients to do. Knowing what they're allergic to, if they have these sensitivities, is also important. Encouraging them to ask questions and take an active role in their care. Knowing the names of their medications, not just the brown one or the red one. What strength that they take, the schedule, and then also taking them as directed. So good compliance and adherence. We see this very often with insulin. You have a patient who comes in and tells us that they're on a specific insulin. Well, if you're taking your insulin as you shouldn't have hypoglycemia. But if you put them exactly on what they tell us that they were taking and they were non-compliant, it puts them at risk for severe hypoglycemia. So making sure that they're taking the medicine regularly, letting us know when they don't. We talked about all of the different ways that errors occur. We talked about patient risk factors earlier. I pointed out multiple use of medications, our pediatric population, elderly patients as well. Health literacy is huge. It's low, specifically in the South, and so maybe not just assuming that we as healthcare professionals have the same level of, or that our patients have the same level of literacy that we do is important as well. I'm going to have to skip through some of this. We talked about drug information. One of the things I want to close with and make sure that you all are aware of is that Lucian Leaf wrote To Err is Human, which is a document that's quoted often when it comes to errors in any environment. And what I like to say is that incompetent people are at most 1% of the problem. The other 99% are good people trying to do a good job, make very simple mistakes, and it's the processes that set them up to make those mistakes. And so towards the end of the lecture, you will see some things that we do to evaluate whether or not an error is related to the system, which puts us over in this category. So they didn't mean to do it. Well, they didn't mean to do it. There were potential system errors, all the different things that may lead to, if we put someone else in this environment, they can make the same mistake, or whether there was sabotage, malevolent damage, suicide. And we've seen some of those cases come up recently. Take a look at Mount Carmel Hospital in Columbus, Ohio, and their physician who was assisting patients with transitioning, which is currently illegal in our country. And so there are some criminal charges, pharmacist accountability and responsibility with that as well. And so all of that to say that when we're looking at errors, that we want to point back to all the things that we can do within our systems, all the things that we can evaluate, getting down to the root of why an error occurred, or what we can do to make it safer, to protect our licenses, our patients and our prescribers, everyone who's basically involved in the care of the patient, to keep everyone safe. So let's see here. I'm out of time, I think. At least the clock is showing that.
I think they disconnected. So
Yeah. Okay.
have us.
Yeah. So for the system elements, again, we look at the formulary system and what we are carrying there. Personal management comes into that, making sure we have enough staff. Lines of authority and responsibility are important. Ongoing evaluation of quality improvement and peer review, and then access to appropriate clinical information are some of the system reasons that we may run into errors. Procurement, policies and procedures, we talked about storage and security, making sure that we're not using medications from the gray market, which means that they may be counterfeit medications. That comes up often with drug shortages. Minimizing the use of patient home medication, and we've talked a lot about computer systems. Reporting, culture of safety, we've talked about all of that. Here are the resources that are available to you if you'd like to go out and take a look that I referenced. And that is it. I think my stories went long today. I've never not been able to get through all of that. Any questions? All right. Well, you all have a wonderful